Tuberculosis screening in the US relies on two main tests, the tuberculin skin test, or TST, also known as the Mantoux test or the Mantoux test, and the interferon gamma and release assays, such as the QuantiFERON TB Gold or TB Spot TB. These tests detect prior sensitization to TB antigens. They cannot distinguish, though, between a latent or active infection or disease. You need to rely on clinical context, chest imaging, microbiologic studies to actively diagnose a active infection versus latent. So it is critical to differentiate latent TB versus active TB. An individual that has latent TB has live but inactive bacteria and is unable to transmit the infection, while those that have active TB, active disease, have replicating bacteria and they could spread TB. Latent patients are asymptomatic with normal chest x-rays versus active TB presents with cough, fever, and weight loss. Both groups will test positive on TST or IGRA, but treatment and infection control plans differ. So the Mantoux test involves intradermal injection, so a zero point 0.1 milliliter purified protein derivative into the forearm. If previously exposed to TB, immune cells recognize the antigen and produce a delayed hypersensitivity reaction that leads to a palpable induration. It takes about 2 to 8 weeks after exposure for the immune system to mount a detectable response, and the reading has to occur between 48 and 72 hours after administration. When administering the test, the needle is inserted just beneath the skin to create a 6 to 10 millimeter wheal. It is important to follow infection control procedures and ensure accurate intradermal placement. The site should not be covered or massaged, and patients should be instructed to return within 48 to 72 hours for reading. Proper technique is crucial for reliable results. When you read the test, you will palpate the site to identify if it's indurated, the raised firm region, not the redness. And then the diameter of induration is measured in millimeters across the forearm. If no induration is present, you'll record 0. Accurate measurement and documentation are essential since interpretation depends on the patient's risk category and comorbidities. Therefore, when we're looking at kind of thinking about this, interpretation will depend on risk factors. A negative test less than 5 millimeters in high-risk individuals. It's less than 10 millimeters in those with potential exposure, and less than 15 millimeters for low-risk persons. A contraindication includes prior severe reaction to PPD or prior BCG vaccination, which can cause false positives. People that have known positive results should not be retested as repeated exposure can actually cause local skin necrosis. An induration of greater than 5 millimeters is considered positive for HIV positive patients, recent TB contacts, or immunosuppressed individuals. Greater than 10 is positive for recent immigrants, IV drug users, and healthcare workers, and greater than 15 is positive for those with no known risk factors. These thresholds will help us balance sensitivity and specificity, ensuring high-risk individuals are appropriately identified for further evaluation. So again, individuals with no TB risk factors greater than 15 millimeters in duration is positive. However, broad screening of low-risk populations is not always recommended because there are false positive scenarios. You always want to combine a TST result with a clinical assessment, X-ray findings, and patient history. If latent TB infection is suspected, preventative treatment should be initiated to reduce the risk of reactivation. Interferon gamma release assays, or IGRAs, are blood tests that measure the immune response to Mycobacterium tuberculosis antigens, which is the bug that causes TB. And they're based on T-cell release of interferon gamma when exposed to TB-specific peptides. These assays cannot distinguish latent from active TB, but are useful for identifying infection. IGRAs are preferred for patients who received the BCG vaccine, since vaccination does not cause false positives, unlike the skin test. An IGRA can be used instead of, but not in addition to, a tuberculin skin test. They are ideal for patients unlikely to return to get a TST read, or for those who are vaccinated with BCG. However, they're not recommended for children under 5 due to limited validation. Results should always be interpreted alongside a clinical finding, chest x-ray, and epidemiologic risk factors or risk findings to guide any treatment decisions. Now, in certain cases, both TST and IGRA may be useful, particularly when the initial test result is negative but suspicion remains high, or when confirmation is needed for indeterminate results. Using both can help clearly clarify infection status in healthcare workers or immunocompromised individuals. And importantly, IGRAs do not boost immune memory, so repeated testing does not alter future results as a skin test can.